Every 1.8 seconds, someone dies from a cardiovascular disease. How does someone who's doing everything right still end up becoming another number in the world's leading cause of death?
The cholesterol we observe for adults, for most of us, unfortunately, it is over 200. So this level of cholesterol is obviously associated with our mistakes in the diet. It is obviously associated with other risk factors such as overweight and obesity, when we usually observe something we call atherogenic dyslipidemia.
What cholesterol really is and why the balance matters so much?
Obviously, cholesterol is very much needed. Do not focus on glucose only. Don't be glucose-centric, because you may have your patients with expected levels of glucose, but in these patients is with elevated levels of LDL cholesterol, with blood pressure, when this patient is obese, this risk, cardiovascular disease risk, is still critically increased, right?
Professor Banach, how early in life should people start paying attention to their cholesterol levels, and what simple habits really matter?
Check your LDL, simply check your LDL at any occasion, and do not ignore your LDL level, and do not allow your physician to ignore LDL cholesterol level as well. When we smoke, when we have underweight, obesity, when we have established atherosclerotic cardiovascular disease, when we have chronic kidney disease, when we do not have enough exercise, this HDL cholesterol is going to be dysfunctional. So let's not only focus on cancer, which is critically important in order to have a early diagnosis, effective treatment, and so on, but please also focus on cardiovascular diseases. Simple tips for healthy heart, showing that we have 12 different risk factors that might be associated with the healthy heart, including, for example, alcohol consumption and stress you've mentioned.
Yes.
Which is probably the most difficult for all of us.
To help us uncover the truth, I'm joined by Professor Maciej Banach, one of the world's foremost and the most celebrated thought leaders in lipidology and cardiovascular prevention. Professor Banach, welcome to Drug Diaries. Before we jump into today's episode, I just want to say something from the heart. Over 93% of the people who watch this podcast regularly haven't subscribed. And listen, I get it. Life is busy. You click, you watch, you move on. But if you've ever felt like this show brings you value, if it has made you think, sparked a new idea, introduced you to something inspiring, then I have a small favor to ask. Please hit that subscribe button. It might not seem like much, but to me, it means everything. This podcast has always been a labor of love. No sponsors, no script, just honest conversations with people trying to make a difference in the world of healthcare. And your support, your one click, helps me keep doing that. It helps more people discover these voices. It helps this community grow. So if you're here, if you believe in this, please consider subscribing. Thank you for being here. Now let's get into the episode. A few weeks ago, I lost a friend. He was 42, fit, healthy looking, full of life. The kind of person who never missed a morning run, who laughed loudly, who always ordered a salad. One morning, he didn't wake up. A sudden cardiac episode. No warnings, no second chances. And like so many others, we were left with the same impossible question. How? He didn't smoke, he exercised, he looked after himself. So how does someone who's doing everything right still end up becoming another number in the world's leading cause of death? Every 1.8 seconds, someone dies from a cardiovascular disease, and most of them never saw it coming. The silent killer often is in stress or lifestyle. It's something invisible, something most of us barely understand. Cholesterol. Yes. What if we've been thinking about cholesterol all wrong? What if the problem isn't the molecule itself, but our understanding or misunderstanding of it? To help us uncover the truth, I'm joined by Professor Maciej Banach, one of the world's foremost and the most celebrated thought leaders in lipidology and cardiovascular prevention. His groundbreaking research has shaped global guidelines, changed the way we treat cholesterol disorders, and saved countless lives through awareness and education. Today, we'll explore not just the science of heart disease, but the human story behind it. What really drives it? What you can do about it? And why understanding your cholesterol might just be the most important thing you ever learn. Professor Banach, welcome to Drug Diaries.
Thank you very much for for the invitation. It's a great pleasure to have such an opportunity to discuss about this critical issue.
Likewise, Professor Banach. I'm so honored to have you on the show today. It's a real privilege.
My apologies, we haven't had the opportunity to meet earlier. It is obviously my fault, but I'm very happy that finally we are able to discuss about this. And thank you for this because having more people that would like to discuss and explore the issue of the cholesterol by itself, it is critically important for the education.
Absolutely. And you know what fascinates me about heart disease is that it's often described as a silent killer. And it truly is. Most people don't feel any pain or symptom until it's far too late. And yet it's responsible for nearly 18 million deaths a year globally. And that's one in every three deaths. So, Professor, I would love to start by understanding why something as well known as cholesterol still catches us off guard and what makes it so misunderstood.
It is probably one of the most critical question concerning LDL cholesterol and cholesterol by itself. But because if we look at the number of cardiovascular death we have, and a new paper by the Global Burden of Disease has just been published, and it showed it is not even 18 but over 19 million deaths. But the critically important point is that most of those deaths, about 70%, are due to the atherosclerotic cardiovascular disease. So that is why we are able to prevent those diseases because they are due to the modifiable risk factors, right? And one of these risk factors is obviously LDL cholesterol or cholesterol, because we might discuss whether we should focus on LDL cholesterol, maybe apolipoprotein B or non-HDL cholesterol, but probably we'll have some time in order to discuss it further during this interview. And the issue, if we look at the different risk factors, and everyone knows, probably most of us knows the blood pressure level we have, right? Because we understand why important is measuring of the blood pressure, because it's associated with the risk of the heart of the heart attack, of the stroke. And we simply, if we have elevated blood pressure, we feel not well, right? So now we have a headache, we have arrhythmias, we have a fastened heart rate, and many other different risk factors and the symptoms, right? It is the same with obesity. Simply, obesity is well seen, let's say, because we know that we usually know our BMI, right? It is the same with diabetes, because diabetes is associated with very quick different symptoms, and we understand how diabetes is associated with the cardiovascular disease risk. And obviously, smoking and many others, we can discuss it, right? But LDL cholesterol by itself is really a silent killer, because um, elevated levels of cholesterol usually appears even at childhood, because we have a pandemic of the obesity, metabolic disorders in childhood, during the childhood, in even adolescents, young adults. And these elevated levels are obviously associated with the fact that there is a progression or start of atherosclerosis process, right? But it is very individual, obviously, but for most of us, this process is very long, take into account time. So we do not feel that we have elevated levels of LDL cholesterol. And if we feel it, it is probably too late. Not too late because it is obviously associated with the risk, but too late because if we would start intervention, and it needed to be pharmacological intervention from the very beginning, but the lifestyle changes. So in other words, if we would invest in our health as early as possible, when we are young. I am 48. I can realize that you are a little bit younger than I am. So that is why, if we would start earlier in the situation that we have no symptoms, but we are interested what is going on with our body, whether we can improve our health results, right? It would be the best methods in order to avoid the situation that we would have a um, problem with the exercises, because we feel pain in the chest. We have a problems with other symptoms, because we may notice when we go upstairs, we need to wait because we have a problem with dyspnea and many other different symptoms that we haven't had before, right? And these are the symptoms of something which is called ischemia, right? Ischemia due to the atherosclerosis. But if we go to the doctors with those symptoms. It is a failure both for the doctors, for the physician, and for the patient, because it means that we weren't able to be very early with the intervention. Because if we would start earlier, at the age of 20, 30, or something like that, we would say my level of LDL cholesterol is elevated, right? So let's do something. Let's improve our diet. Let's have regular exercises. Let's maybe if we fail, let's consider a small dose of a drug in order to be on the LDL cholesterol target, right? So this expected, take into account our risk target of the LDL cholesterol, then we might avoid cardiovascular events by 60%. Then we may be very successful in the situation that there will be never atherosclerotic cardiovascular disease. But as you've mentioned, the truth is that because we do not feel it. For example, if there is a patient in my office and I say, it is you have elevated level of LDL cholesterol, your risk is high, taking into account age, taking into account other risk factors you have had over there, right? So I would like to suggest you to start obviously lifestyle changes, but also the a small dose of statin in order to have your LDL cholesterol as early as possible and as low as possible for lifetime, right? And these patients say, why? I do not feel anything. I feel very healthy. I do not have any symptoms. And you are saying to me that this treatment is not only to reduce LDL cholesterol, but it is lifetime treatment, right? So the patients usually um, try to find the explanation not to do it simply, right? So they are looking for in the internet. There are many fake news concerning the LDL cholesterol, cholesterol by itself, as well as treatment, especially statin. You know it very well that there is a number of data concerning the statin therapy. And in the end, it might happen something that you unfortunately mentioned concerning your colleague, that he was healthy, but probably he was undiagnosed. Take into account, I predict a genetic predisposed disease with elevated levels of LDL cholesterol, lipoprotein and many other, or maybe other disease, because it happened that it was a very large MI, a myocardial infection,
Yes.
and due to the spike, it was dead. But if your colleague
Mm.
would have a chance to have this diagnosed earlier
Yes.
at the childhood, for example, because for heterozygous FH and FH, we try to be as early as possible and to diagnose this disease at childhood, because at the age of 6, we might start statin therapy and we might be very effective. And the expected lifetime for those patients is the same like for the patients without this disease if we start earlier. I am very sure that we might avoid
Mm.
most of these events, cardiovascular events, which are life-threatening as it was with your colleague, right?
Right. And Professor Banach, going back to the basics, when people hear the word cholesterol, they almost instantly think it's bad, like sugar or trans fats. But the truth is, cholesterol is essential for life. It helps us build every cell membrane in our body, and even hormones like estrogen, testosterone. So, could you help us understand, in the simplest term, what cholesterol really is and why the balance matters so much?
It is good that you have just said that if we think about the cholesterol, we should rather think that every kind of cholesterol is bad, because it is better to understand. It is obviously a kind of simplification, right? Because obviously cholesterol is responsible for our energy in our body, right? ATP and production, many other different things associated with our every existence. On the other hand, it is associated with the synthesis of hormones, of enzymes, of vitamins. It is associated with the transport, blood-brain transport. It is associated, obviously, with the endothelium building and many other different, very important things to our body.
Right.
But we need to understand that these cholesterol we usually product by ourselves. So our liver is associated with the production of this cholesterol, and if someone would ask what level of cholesterol is enough for all those pathways and mechanisms and important functions, It is, we say that it is usually this level of cholesterol that we observe in the newborn. So it is about up to 40 milligrams per deciliter. So 40 milligrams per deciliter we observe by LDL cholesterol in the newborns. And obviously we are talking about the total cholesterol, which is involved in all those mechanisms. And that is why, and all those processes, and it is about 70 milligrams per deciliter.
Right.
If you look at the mean number of LDL cholesterol, mean level of LDL cholesterol we observe for adults, for most of us, unfortunately, it is over 200,
Oh,
right?
wow.
So this level of cholesterol is obviously associated with our mistakes in the diet, right? It is obviously associated with other risk factors such as overweight and obesity. When we usually observe something we call atherogenic dyslipidemia. So this elevation of cholesterol, which is exogenous cholesterol from the diet, right? Unfortunately works like a toxin in our serum
Right.
of blood. And this toxin, so this elevation of the cholesterol, causes the injury of the endothelium and starts the process of that rheumatoid plaque formation and atherosclerosis. So that is why, obviously, cholesterol is very much needed, but the level of cholesterol we require for those processes is completely enough from the endogenous synthesis. And if we have too much cholesterol in the diet, this cholesterol simply work as a toxin in our serum. So it is the main problem. So that is why it is obviously also a kind of simplification, because it is we do not have time in order
Yes.
to discuss about all those mechanisms. But I believe this simplification might help everyone to understand that we should be very careful with the diet, well-balanced diet, right? And if we have liver lipid disorders, we should have a hypolipidemic diet, right, in order to reduce this level of LDL cholesterol with the diet itself, because it might cause even, obviously, an average reduction of the LDL cholesterol by about the 12 to 17% with the Mediterranean diet, hypolipidemic diet, DASH diet, and so on. So this is the main issue. But uh, one more comment, if you allow me,
Sure.
because I have many patients that they come to my office and say, uh, Dr. Banach, I have elevated LDL cholesterol, but do not worry, because my HDL cholesterol is also elevated, and you know it very well. But this HDL cholesterol is good for health, so that is why it diminishes the effect of the elevation by LDL cholesterol. It is fake news. Come on,
Really.
please do not try to explain and the fact that you have elevated LDL cholesterol with the fact that you have let's say, good cholesterol elevated as well. There is no good cholesterol, obviously. Very briefly, HDL cholesterol have anti-atherogenic effect, anti-inflammatory, anti-oxidative, and so on. But unfortunately, and this is also another simplification, but it is such simplifications help us to understand the issue of the cholesterol as a silent killer. With many processes we have, with when we smoke, when we have underweight, obesity, when we have established atherosclerotic cardiovascular disease, when we have chronic kidney disease, when we do not have enough exercise, this HDL cholesterol is going to be dysfunctional,
Right.
simply. So most of the level of HDL cholesterol then is dysfunctional, and this dysfunctional HDL cholesterol, unfortunately, is also atherogenic, not non-atherogenic. So that is why do not think about the HDL cholesterol as something that might help us with our health. Obviously, and this is the reason that now we do not use HDL cholesterol at all. The only thing we use HDL cholesterol when we calculate non-HDL cholesterol. And non-HDL cholesterol is a mass of the all atherogenic particles we have in our body. So please focus on your LDL cholesterol. Obviously, if you have such an opportunity and in your laboratory, and the physicians prescribe to measure ApoB, apolipoprotein B, it is probably the most predictable parameter of the lipid profile, because it measures all the number of the particles which are atherogenic in our body. And this is something we should focus, take into account also the treatment, the level we need to have, take into account our risk. and many other different things. And I'm not sure, tell me if I'm too complicated. I try my best to still
Absolutely not.
simplify this message.
Yeah, and I think
Mhm.
just one question on that. How would you explain atherogenic to someone who doesn't have the right sort of who doesn't have the scientific background?
Yeah, obviously, great question, because for us, atherogenic is
Yeah.
quite normal to understand. But this is the issue if we measure lipid
Hmm.
profile and if we see that the level of LDL cholesterol, non-HDL cholesterol is elevated over the level recommended for the given patients. For example, if I am a person of the age 48,
Hmm.
my score suggests that I am at the low level of low risk. If I do a risk stratification for
Sure.
myself, and if I using European score algorithms, right? And so my level is low. So my level of LDL cholesterol I should have is taking into account the recent guidelines below 115 milligrams per deciliter, right? So if I have a level of LDL cholesterol over 115,
Right.
and at the same time we have also other disturbances in the lipid profile, it means that my lipid profile is atherogenic. So it is associated
Hmm.
as in the stepwise manner with the progression of atherosclerosis simply. So that is why we need to do something in order to reduce this LDL
Yes.
cholesterol and to the level it is recommended for me, for you, for the patients that we meet, and then we simply reduce the risk or even avoid the risk to have a progression of atherosclerosis. Something we expect to have for all our patients, and we know how to do it, because when I studied, it was over 20 years ago,
Hmm.
23 years ago. I ended I graduated. During the study, nobody was able to tell me that atherosclerosis is able to be regressed,
Mm.
right? Um, uh, since 2006, 2007, there were two trials with starting high intensity statin therapy, and we've probably for the first time showed that we might reduce atherosclerosis
Hmm.
process, we might regress atherosclerosis process. And now in 2025, we know how to do it effectively. So obviously we are not so effective uh, that it is something like this,
Yeah.
because for example, if the whistle is narrowed
Hmm.
by 50% with atherosclerosis, even though we are very much effective with the intensive statin therapy and intensive lipid lowering combination therapy with other non-statin drugs, and we might reduce LDL cholesterol even to the levels below 40, because the lower is better, simply for especially for very high risk patients. This regression is unfortunately not so fast as we would expect. So we might regress atherosclerosis process on average about two few percent per year.
Right.
And you remember we are talking about the 15% regression narrowing of
Hmm.
that rose of the whistles. So that is why we need to be treated for many years in order to not only regress the lipid core and the atheroma plaque by itself,
Hmm.
but also to stabilize, because the treatment is also associated with something that causes that this atheroma plaque that exists in our result is stabilized, and it is not associated then with the risk of the to be ruptured and to cause the ischemia, for example, ischemic stroke or a myocardial infection.
Right. And Professor Banach, how early in life should people start paying attention to their cholesterol levels, and what simple habits really matter?
You know, uh, these are so important questions, because the earlier the better, right? So, for example, now in Poland we introduced something which is called lipid profile measurement at the age of 6, during the 6-year health balance of the children, right?
Hmm.
Why? Because we are not so effective with the heterozygous FH diagnosis, and we
Right.
diagnose heterozygous FH too late in most of our patients, right?
Sure.
So for the adults it is about 40 plus years of age, so it is very late. For children it is about 12 years. So that is why when we have a universal screening, so every child might be measured with lipid profile, we might simply have this level of LDL cholesterol in order to see whether whether this child is at the risk of the heterozygous FH. And it is not only important for this child, because due to the cascade screening, we treat the whole family, right?
Yes.
So we can also measure cholesterol, LDL cholesterol for parents, for grandparents. And please imagine that if we have a child at the age of 6, usually parents are at the age of 30 plus, and the grandparents are usually at the age of 50 plus.
Yes.
So even though they may have heterozygous FH or other genetic predisposed disease associated with the synthesis and metabolism of the cholesterol, we still have an opportunity to prevent cardiovascular events, or even though these patients are after the event, to treat them optimally to avoid cardiovascular deaths and recurrent cardiovascular events. So this is so important, especially in the time we are living, when we have, as I mentioned before, and the pandemic of obesity, underweight, pre-diabetes, metabolic disorders, and many others. So that is why, as early as possible, at any occasion, it is usually my response for it. And for example, in Poland, it is also great that we are able to convince the government, the Ministry of Health, the National Health Fund, to start with the program which is called My Health. My Health is dedicated for 20 plus people.
Right.
So people at the age of 20 and more, obviously it is not obligatory, it is facultative. If I would like to have this measurement, I can do it. Can go to the can, let's say, fill a kind of survey, and based on this survey, they have indications for different measurements, health measurements, for free, obviously. And that is why we are able also, not only at this mentioned health balance at the age of 6, but also those at the age of 20 plus, we are able to find severe lipid disorders or even lipid disorders, and to say at the very beginning, you needn't do anything at this moment, take into account the treatment, but please invest in your health at the age of 20, 25, 30, with lifestyle changes, with the good diet. Let's improve your diet with the dietitian. I have a great collaboration with dietitians. Let's try to find a personalized way to have a good training for you, because obviously it is not an issue to say the patient with obesity, let's please run 5 kilometers every day, right? If this patient was inactive completely or sedentary before. So that is why we need to personalize this training. So for most of these patients, we might be very effective in order to avoid the disease. And this is something we need to talk, because I don't know what is your expression as a patient, as an expert, which you have with many interviews and meetings with many people. But for example, in Poland and in the part of the Europe I represent, Central Eastern European countries, we mostly focus on cancer.
Right.
Everyone knows what is cancer, and everyone knows why cancer is life-threatening condition, and this diagnosis of cancer cause that we are completely we fear simply,
Yes.
right? And this is normal. It is something which is quite normal. But why it is not the same issue with cardiovascular diseases,
Exactly.
which are responsible for twice more deaths in comparison to cancer. So let's not only focus on cancer, which is critically important in order to have a early diagnosis, effective treatment, and so on. But please also focus on cardiovascular diseases. It is something I can, just one word. We are now developing something which is called cardio-oncology area. Why? Because we've noticed that in those patients with cancer, which are very well treated, because it is very personalized therapies for most of those patients. So the, let's say, progression free survival as well as overall survival is very long now for many of those diseases and those treatments.
Right.
We've noticed that those patients are unfortunately not treated well, taking into account the cardiovascular risk factors, and they may die not due to the cancer, but due to cardiovascular disease. And this is a little bit nonsense, because oncologists are so effective with the treatment of cancer, but due to the fact that they do not measure and do not look at cardiovascular risk factors, including LDL cholesterol. I don't know if you know that LDL cholesterol is measured in those patients in 5% only
Really.
of this population. So that is why those people are getting to be on the LDL or on the cardiovascular disease risk and may die due to the MI, due to the stroke, being well treated with anti-cancer therapies.
Right. And Professor Banach, we've been seeing incredible leaps in how we treat cholesterol from the discovery of statins decades ago to
Mhm.
new options like PCSK9 inhibitors. And now, even gene editing tools like CRISPR that could change the way our bodies handle LDL permanently. And it's wild to think we are talking about turning off genes that cause high cholesterol, something that sounds like a science fiction. Um, but Professor, what do you see as the most exciting development in this field, and how close are we to making these innovations accessible to everyone?
You know, this another great question because indeed, for many years, starting 1978, Professor Akiro Endo, that died this year, unfortunately, for the first time was responsible for introduction of the statins to the market, simply to the science, right? And at the very beginning, we have mevastatin. Atorvastatin obviously was the second one, and but for many years, probably due to 1994 for S trial, we didn't know whether those drugs are so effective or not. And Forest Try for the first time showed us that this drug status might simply prolong
Mm,
our life, right, due to the LDL cholesterol reduction.
right.
And since that time, it is also critically important to mention because it is an ongoing discussion on the statin safety. These drugs were probably the best investigated ever in comparison to other drugs in medicine because we have thousands of randomized controlled trials with studied. And it was the first amazing step we did for the lipid disorders. And I'm a little bit sad that we were not able to give a Nobel Prize for the Professor Akira Endo that he simply deserved. But if we are talking about the other drugs you've mentioned, it is the obviously we've noticed also, and especially taking into account that we have more and more data that our level of LDL cholesterol should be lower and lower, right? Because it is another discussion that take into account the fake news. Someone says, okay, 10 years ago, the LDL cholesterol you indicated was 100.
Mm,
Now you are talking about the 55 or even 40. So it is something which is associated with big pharma,
yeah.
corruption, and something like that. You know, the issue is that it is simply associated with the development of science, right? Because we have a more and more better and better methods, including also looking at the atheroma plaque by itself within the IVUS, OCT, and the NIRS, and many other different methods. And we have more and more data suggesting, and this is critically important, that 55 is not a coincidence because if we have a 55%, a 55 milligrams per deciliter LDL cholesterol level, it is associated with the regression of atherosclerosis. This is this one line,
Hmm.
and the stabilization of the plaque. And these two lines are at the level of the cross at the level of the 55. So it is not a coincidence that everything is happening below 55. It is associated with simply with the regression of atherosclerosis and safety concerning the cardiovascular disease events, right? So we might say that in those patients below 55, if they are obviously looking at the other risk
Mm,
factors as well, because we are not LDL centric,
yes.
obviously, we need to look comprehensively for the patients. For patients, we might avoid 100% events. But let's talk about the main questions you've noticed. Uh, it is probably lipid disorders area is probably the most developing one in the world,
Mm,
because as I said, for many years we had only statins. We had ezetimibe since 2002, another great drug that works synergistically with the statins, taking into account that it simply inhibits the cholesterol from the intestines and from the bile, right? So it also reduces LDL cholesterol very effectively by 15 to 20%. But we have also another drugs we introduce. It was a kind of coincidence, I don't know, the introduction of the PCSK9 inhibitors, because they were also patients with very low level of LDL cholesterol, even 12, 15, 20 milligrams per deciliter. And my colleagues from France, from INSERM in France, in Paris, starting to looking for the reason why these patients have such a low level of LDL cholesterol. And they introduced something which is called PCSK9 protein, and something, a kind of genetic predisposition, loss of function of PCSK9 protein that do not bind to LDL cholesterol receptor, and do not is not associated with the damage of this receptor in the hepatocyte. So that is why we have a lot of receptors on the surface of the hepatocyte if we simply inhibit PCSK9 protein. And that is why those levels might be very, very low, right? So that is why, based on these, PCSK9 inhibitors were introduced as an add-on to statin therapy, or statin ezetimibe, as a part of the combination therapy. And since that time, in fact, because unfortunately ezetimibe was not well reimbursed and it was used only in 3 to 5% of the patients. But since the era of the PCSK9 inhibitors, we started to talk also of something not only at the intensive statin therapy, which is critically important, but intensive lipid lowering combination therapy. Because you cannot imagine that now having high intensity statin therapy, which is responsible for rosuvastatin and atorvastatin highest doses by about 50% reduction of the LDL cholesterol, statins and ezetimibe 65% reduction, statins and ezetimibe and PCSK9 inhibitors even 85% reduction of the LDL cholesterol. And these are monoclonal antibodies at the very beginning for PCSK9 inhibitors, but now we are investigating within the trials oral PCSK9 inhibitors, something which will be another game changer, as I strongly believe. For other drugs, because this is not the end, and this is good because it helps us to have a kind of personalization of the treatment. We also noticed that we have drugs that may inhibit in the enzyme which is called ACL, in the same pathway that statins works. And this drug is named bempedoic acid. And we've noticed from the very beginning, it was quite surprising that this drug is a prodrug, so it is completely ineffective in muscles, and it starts to be effective and it is activated only in the hepatocyte. So from the very beginning, we say, oh my goodness, it might be a great add-on to statin therapy and statin ezetimibe, especially in those that may have statin intolerance or may not tolerance or partial or complete statin intolerance. You know it very well that about 10% of the patients may have statin intolerance, taking into account even our largest ever meta-analysis. So we introduced bempedoic acid, and bempedoic acid as a monotherapy and also as a fixed dose combination with ezetimibe. And this bempedoic acid, taking into account the clear outcomes trial that was released in 2023, is associated with 35 to 40% reduction of the LDL cholesterol. So if we have a high intensity statin therapy, bempedoic acid and ezetimibe, it is about 70 few percent reduction of the LDL cholesterol. If we are PCSK9 inhibitors, it might be even over 85%, about 90%. So please imagine that we now may have LDL cholesterol reduced to a very low numbers for most of the patients. Obviously, it is a kind of hypothetical situation, because we know it very well that we have a problem with the non-adherence, right? We have a problem, as something you've mentioned, about the availability of those drugs in many countries, and there are country to country differences concerning the reimbursement. For example, we still do not have bempedoic acid in Poland, despite the fact I try my best to and discuss with the companies to have this drug as quickly as possible. Obviously, there are different levels of reimbursement and criteria for reimbursement for PCSK inhibitors and inclisiran, because it is another, in my opinion, game changer. Because inclisiran was the first drug that used something which is not turning off the gene, but silencing the messenger RNA responsible for the synthesis of the PCSK9 protein, right? And it is based on the 2006 Nobel Prize for silencing of this small interference, for the interfering of the RNA. It is called small interference RNA. It is inclisiran. It is the first in cardiology. Now we have many of those drugs, and inclisiran was a kind of precursor of this group of drugs. And inclisiran is also associated with the reduction of the LDL cholesterol by 50%, but it is administered only twice a year, so it is a very good option for very busy young people, or those that do not want to have every month injections with the monoclonal antibodies, or they simply would like to have a level of LDL cholesterol reduced, having only 2 injections per year. And the final drug I would like to mention, because I can discuss with you for hours, because
Yes.
there are many of different drugs we are investigating now. Now it is obesity therapy.
Mhm.
Obesity therapy is an amazing drug, because it is a CETP inhibitor. CETP is a kind of particle also associated with the metabolism of cholesterol, associated with the transport cholesterol, with triglycerides, and with non-HDL, HDL, LDL cholesterol, and we have had experiences with CETP inhibitors before. It was evacitrapib, tarcetrapib, valcetrapib, and they were all negative, because the main issue associated with the work of the CETP inhibitors, that we simply increase the level of HDL. We have just discussed the HDL issue, and those attempts to increase HDL cholesterol to reduce cardiovascular risk was with niacin. It was negative. They were negative, and with CTP inhibitors were also negative. But my great colleagues,
Mhm.
Professor John Castellane, Professor Michael Davidson, noticed, gosh, it may be not a kind of class effect. Maybe let's focus not on the HDL by itself,
Mhm.
but let's focus also on the reduction of the ApoB LDL cholesterol.
Yes.
And they've noticed that this new, let's say, CTP inhibitor, obicetrapib, is not only associated with very high 100 or 50 or so increase of HDL cholesterol, which is less important but less important, but it is also associated with the
Mhm.
significant, over even up to 40% reduction of the LDL cholesterol, with also reduction of the ApoB, but also, which is critically important, reduction of the lipoprotein delay up to 50%. And lipoprotein delay, we haven't had occasion to discuss. It is genetically predisposed as well, particle of the lipid profile, which is completely independently associated with the cardiovascular disease risk, not only due to the fact that it contains ApoB,
Mhm.
but it also contains a chain of the apolipoprotein little a, and this chain is very similar to plasminogen, so that is why it may have prothrombotic,
Mhm.
it may increase prothrombotic risk, but also it is associated with the pro-inflammatory risk. So that is why it is said that lipoprotein delay is even 6 times more. I would like to use the word atherogenic,
Mm.
as we discussed
Yes.
previously, in comparison to the LDL cholesterol. So that is why this obicetrapib might be also a kind of game changer, because we are looking now not only for the drugs that might be effective for the LDL
Mm.
cholesterol, but here we have also increase of the HDL, the reduction of the lipoprotein delay, and something which is also critically important, which we also notice for bempedoic acid. It also reduces the risk of the new onset diabetes, because you probably have heard that statins, especially high intensity statin therapy, might increase the risk of new onset diabetes. I know that the story is very complicated. My apologies
No,
for
not
it.
at
So,
all.
but I hope that I was able to at least say a few important innovations we have in this field.
Absolutely. I think your coverage was pretty comprehensive. You touched upon every aspect of the treatment options, and that was extremely helpful. Now, the more I've learned about heart disease, the clearer it becomes that it's never just one thing. High cholesterol is part of the equation, but so are inflammation, diabetes, obesity, stress, and even sleep. And it reminds me of a symphony where one instrument is off key and the whole piece starts to fall apart. So, Professor, how do these factors interact? Um, and Are we paying enough attention to non cholesterol aspects of cardiovascular risk?
No, it is another, I don't know, probably you probably have all the most important questions during this interview because it is so critically to remember to understand that and we discussed for many years with our great colleagues diabetologists, do not focus for glucose on glucose only, right?
Mm.
Don't be glucose centric because you may have your patients with well level with expected levels of glucose, but if this patient is with elevated levels of LDL cholesterol with blood pressure, when this patient is obese, this risk, cardiovascular disease risk, is still critically increased, right? So that is why we are very happy that a few to several years ago, new drugs for diabetic patients and obese patients were introduced, such as SGLT2 inhibitors as well as GLP-1 receptor agonists, because they not only reduce and help to have our patients on the level of glucose and hemoglobin A1C, but also they reduce simply cardiovascular disease risk, so, which is critically important. And that is why the hepatologists also say, okay, we shouldn't focus only on glucose, but
Mm.
we should focus on the risk by itself. And this is something we should all remember. We may be very effective with the reduction of the LDL cholesterol. This level might be at the level 15, 20, 30, 40, right? So these patients might be very low with the LDL cholesterol for years. But please imagine that even those patients I've mentioned with loss of function PCSK9 protein, right? So these conditions that also cause that we have a very low level of LDL cholesterol, which are genetically predisposed from the birth. If they have metabolic syndrome, if they have obesity, if they have diabetes, if they do not sleep well, if they have elevated lipoprotein level,
Mhm.
they still may have simply heart attack, ischemic stroke, cardiovascular disease, that. So that is why we always need to understand and remember about the residual cardiovascular disease risk. So it is something which is outside this one risk factor we are focusing. So for example, if we focus on the LDL cholesterol, we may have inflammation-related residual cardiovascular disease risk. We may have a diabetic-related, and many others. If we are focusing on the inflammation, it is also a great area to briefly at least discuss, because we know it very well that atherosclerosis process is always the complex issue of the high level of LDL cholesterol, which is a part of the lipid core of the atheroma plaque, but also inflammation. Without inflammation, there is no atherosclerosis. It is 100% true. And these processes are combined with themselves. So we cannot discuss in a way. Let's focus only on inflammation, or let's focus on your LDL cholesterol. But the issue is that our attempts to reduce inflammation for last 30, 40 years were not
Mm.
effective. We failed simply. We tried to target TNF alpha, interleukin 1.
Mm.
We tried to focus on other parts of the inflammation process, starting from the inflammasome, right?
Yes.
And even with the canakinumab, which was associated with the reduction of the interleukin 1 beta, we observed significant reduction of cardiovascular events, but it was also associated with this significant increase of fetal sepsis.
Mm.
So that is why we know that it's a very sensitive issue. We cannot simply destroy our resistance, right?
Yes.
Immune resistance, right? So that is why now we had a colchicine, an old anti-rheumatological drug, which is very effective in the reduction of the inflammation, and this is within the guidelines, but it is not used by most of the cardiologists due to the fact that it is not well tolerated
Mm.
by the patients. So that is why now we are doing the studies with the drug which is called ziltivekimab, because it is the first drug which is against interleukin 6. And we are now looking forward for the results of the Zeus, Poseidon, and many other different trials with this drug, because we hoped it might be the first drug that might be very effective in the reduction of this inflammation-related cardiovascular disease risk, inflammation-related residual cardiovascular disease risk you've mentioned. So the main message from taking into account your
Mhm.
question is that we we mustn't
Mm.
focus only on one cardiovascular disease risk factor. We always should look at the patients comprehensively.
Sure.
So if we are effective with LDL, let's also try to be effective with obese.
Mm.
Let's try to be effective with the pre-diabetes, diabetes, lipoprotein A, and that is why within the International Lipid Expert Panel, we introduced something, a kind of algorithm which is called ILEV Smile.
Mm-hmm.
So simply simple tips for healthy heart, showing that we have 12 different risk factors that might be associated with the healthy heart, including, for example, alcohol consumption and stress you've mentioned,
Yes.
which is probably the most difficult for all of us, how to be effective against stress.
Mm.
Because if patients came to me and say how I should fight against stress, I said, oh my goodness, I can tell you my personal
Mm.
ways, because for me, if I would like to overcome the stress or stressful situation, I love running,
Mm-hmm.
because it is always good for me, taking into account the stress. I loved cleaning my home, because it is, I put my headphones, I get the vacuum and trying to clean my home. I love going for shopping with my wife, because I see my wife very happy. So this why this also a great fight against stress and many other different situations. But probably all of us have different ways and different experiences how to be effective with this stress. But one critical point: do not focus on one risk factor in order to be, if you would like to be effective with the cardiovascular disease risk prevention.
Sure. And Professor Banach, you've been instrumental in shaping global guidelines and collaborating across borders through the International Lipid Expert Panel. But even with all that progress, there are huge gaps between what we know and what people can actually access. So, Professor, what needs to change at a system level in policy, education, or access to make sure that the science translates into real world health outcomes?
You know, that is why we introduced in June this year something which is called European Program for Prevention,
Right.
right? Because we've noticed that we are not effective at all with the awareness
Hmm.
of this risk factor, and not only lipid disorders but
Yeah.
also other risk factors. Because I don't know if you know that only about 10 to 13% of patients know their LDL or total cholesterol level from last 12 months, and they do not combine and do not connect or relate the atherosclerosis with the LDL
Mm.
cholesterol. They do not recognize this even as a risk factor, right? Because they say, okay, risk LDL cholesterol, let's have a diet or
Yeah.
something like that. But it is not important at all in comparison to blood pressure and diabetes and so on. So awareness means education, right? And that is why, for example, in Poland for last 15 years, we tried to introduce health education at schools.
Mm.
And we are able to do it. It works. We started in September this year after 15 years. So trying to convince the politicians, that
Yeah.
it is critically important. But take into account another discussion, a political discussion, the subject that was planned to be mandatory, it is not mandatory, right? So it is about taking into account my knowledge, only up to 40% of pupils are attending this subject. But 40%, it is still something critically important, because we may educate young people about the diet, about the exercise, about the adherence, about the prevention programs, screenings, and vaccinations, and many other different things that are critically important about, and they can go home and they say the same knowledge based on the evidence-based medicine to their parents, grandparents. So we are we are attempting to have a kind of healthy society that, for many years ago, a great legend of cardiology, Professor Valentin Fusser, introduced in Spain, in the United States, in many African countries within the C program, and many other different programs. So that is why it is not nothing that we introduce by ourselves. We use the best experiences in the world. So education, awareness is critically important. Another critical point is to try to focus on the primary prevention, something we are discussing during this interview, about to invest in our health
Yes.
as early as possible, when we are healthy, when we do not have symptoms. Because I don't know if you know, in 1990s in Slovenia, uh, take into account that the Minister of Health was cardiologist and preventive cardiologist. He understood this is critically important, and he introduced the first in Europe uh, coordinated care in primary prevention, mostly based in 85% based on the education. And in after these 20, 30 years, they have reduction of the they may observe reduction of the cardiovascular events, cardiovascular mortality by over 50%,
Wow.
50% due to this fact. So that is why we tried the same in Poland and many other countries. That is why within this European program for prevention, we simply show the best examples
Mm.
we introduce already in order to please use it. Use our examples in your countries, because having our examples, which was validated, checked, monitored, and something like that, it will be much easier for you to fit to your country and your population. But on the other hand, you need to understand that it is not so easy, because if you go to the politician you would like to say, let's introduce a great program that, for example, Slovenia has, this is please notice 50% reduction after 20, 30 years, and the politician says, after how many years? 20, 30? Come on, my cadency is 4 years, 4 years only.
Yeah,
So that is why I need to focus on the programs with the immediate effect. So that is why, unfortunately, I'm a little bit joking, obviously, now, but in fact, unfortunately, in most of the situation, not. But they much prefer focusing on the interventional programs in those people already
yeah,
with established cardiovascular disease, already with the cancer, because they have an immediate effect, introducing new drugs, new diagnostic, new methods, and so on, new programs. But it unfortunately it changes year by year, because also politicians understand that if you would like to have enough money for health, if you would like to have effective system, we cannot avoid prevention, primary prevention. So prevention
hmm,
is now the most important word we
yes,
usually have within the different discussion. And even in Poland, and even in many, even in Central Eastern European countries, we have had already beautiful preventive programs. So, if you would like to ask me the most important things and challenges, obviously education at any
hmm,
level, right? Health education, um, and obviously focusing on prevention. And one critically point to the ongoing education of the physicians as well,
sure.
because it is not only issue associated with the not adherence, because it is so easy to say for us, for physicians, okay, and we are not effective because the patient is not adherent, okay, and from in many situations it is true, but on the other hand, in many situations, unfortunately, we have something we recognize as therapeutical inertia. So the mistakes that we are doing take into account not suitable doses of the
Hmm.
drugs, not a lack of combination therapy, maybe too late effective therapy we introduce to the patients. So that is why we also need to have an ongoing education to be the most effective in the diagnosis and treatment with our patients.
Sure. And Professor Banach, I understand that we've got time constraints, but I've got another two couple of quick questions around some personal reflections, if you allow me, please. So, one is Professor Banach, you've spent your life fighting the world's biggest killer, and you've helped shape how millions think about prevention. But I always find it fascinating to ask what keeps someone like you personally motivated to keep pushing, researching, teaching? Was there a particular patient, a mentor, a moment that shaped the way you see your mission today?
It is quite interesting question, because uh, in fact, at the very beginning, I wanted to be a cardiac surgeon, right? And I started my PhD at the cardiac surgery department. And then I've noticed something which is critically important, that there are so many patients that come to the hospitalization at the Department of Cardiac Surgery with the level of atherosclerosis with only cabbage.
Oh my God.
So as an only method in order to help these patients. But on the other hand, I also have noticed that after cabbage, so after the bypass, right, for those patients, cardiac bypass we have for those patients, we might help those people to live longer, right?
Mhm.
So that is why there are two things. So we might be effective, but why for so many patients we weren't effective enough in order to avoid the situation that only cardiac surgery was the only method in order to help this patient. So that is why and then I also focus on the complications of the cardiac surgery, including the atrial fibrillation,
Hmm.
postoperative atrial fibrillation. And I've noticed that LDL cholesterol was an independent risk factor. The preoperative atrial fibrillation was independent risk factor, and statin therapy was an independent protective factor in order to avoid this complication, which was postoperative atrial fibrillation and postoperative dementia, because it was another part of my on my investigations. So that is why it was the probably the point I said, gosh, prevention is something we need to focus, and lipid disorders is something we need to focus in order to avoid atherosclerosis progression in most of the patients, in order to avoid the situation that we have a so progressed atherosclerosis that the only cardiac surgery might be helpful. So it was at the very
Mm.
beginning at the Department of Cardiac Surgery. I wasn't able to be cardiac surgeons because these were times in Poland that it was almost impossible for people that weren't from the, let's say, doctor's family, and I am the first physician in my family, so that is why, as you can understand, it was
Yeah.
not so easy. But it was a great coincidence that I moved to cardiology
Hmm.
and I started specialization in cardiology. And it was probably the best thing that could have happened to
Wow.
me, because I'm so happy that I can continue this way, and this idea I had looking at the patients at the cardiac surgery department.
Right. And my last question for you, Professor Banach, if you could leave everyone listening with one message, something they could remember years from now, what would it be?
I would say something that we try to say always: check your cholesterol. Simply be aware of your cholesterol, because I have so many patients. Even today, I will have a patients, very young patients, that at the age of 49, after few events already, and the only issue is that he wasn't aware that LDL cholesterol is such an important risk factor, because for him we have two and different conditions, because it is not only heterozygous FH but also elevated lipoprotein tau, and this elevated lipoprotein tau simply amplified this risk associated with the heterozygous FH by itself. And that is why if this patient was diagnosed and was aware of LDL cholesterol as a risk factor at the age of 20, probably we would have been able
Mhm.
to avoid all those events, and this patient was as a completely different quality of life, taking into account his limitations, because he is after few events already, right? But nevertheless, we are able to help him now, and we are doing this. So check your LDL, simply check your LDL at any occasion, and do not ignore your LDL level, and do not allow your physician to ignore LDL cholesterol level as well.
That's a wonderful piece of advice. And that brings us to the end of our today's episode. And after this conversation, one thing becomes crystal clear. Heart disease isn't just a story about medicine, it's a story about awareness, about small decisions that shape the rest of our lives. We live in a world where people track their steps, their sleep, their calories, but not their cholesterol. We worry about the next meeting, the next goal, the next bill to pay. And somewhere along the way, we forget to check the very thing keeping us alive. So, what Professor Banach reminded us today is that knowledge is prevention, that behind every scientific paper, every breakthrough is a message meant for all of us. Your heart is not invincible, but it's not your enemy either. It's quietly working for you every second of your life. And maybe, just maybe, it's time we start working for it too. So if you're listening right now, maybe this is your sign to book that test, to take that walk, to start caring a little earlier than you thought you needed to. Because the truth is, prevention doesn't start in a lab, it starts with awareness, it starts with you. Professor Banak, thank you for reminding us that science can save lives, but understanding can change them. And to everyone listening, take this episode as a gentle nudge to look inward, to listen to your body, and to treat your heart with respect it deserves. Thank you, Professor Banach.
Thank you. It was a great pleasure. Thank you very much for the invitation.
Thank you so much for joining today.